So my next talk is on the technique of doing an arthroscopic Bankart repair, the knotted technique, which is the technique I prefer. And I will tell you, before I just show just two quick videos of technique, which you could have done on any YouTube today or anywhere you can get a video and watch it. So I will not just show just two videos. I have a live video and I have an animated video, but I'm going to tell you first in 8 to 10 slides why I do what I do. So that's the main part of the talk, why I do whatever I do. I'll give you an explanation behind that. So first of all, those who are youngsters, I can see some female as well as male fellows behind. There are certain basic equipment which you have to have. I won't go much into it. You need the full fiber optic system, the optical system, as well as certain special instruments, the cannulas, the drapes, and certain anchors. I prefer to do my arthroscopic Bankart repairs in a lateral position. I did lateral. I grew up, I was trained in lateral. I did beach chair for 3 or 4 years in between, but I'm back to lateral for the last 15 odd years again. So lateral is my preference for operating or doing arthroscopic Bankart or stabilization procedure. And of course, we keep the patient tilted. You want the glenoid horizontal to the floor. And this is how, this is the most important slide. Yesterday, we were operating in a hospital where we had not operated earlier, and my fellow who is sitting there, Nandini, was very good in making sure that the OT is organized like this. OT has to be organized. You need the space around the head side so that you can move around anteriorly and posteriorly. You can memorize this slide, extremely important. 3 portals is what I use, pretty standard: posterior, anterosuperior, and anteroinferior. And I have special cannulas which allow me to switch my scope from posterior to anterosuperior without having to remove the cannula. So that has been my preference for years, and I like to see the whole operation from the anterosuperior portal, from here. I still see many surgeons looking from the posterior portal for the whole operation. I like to be here, and the reason is from posterior, this is how you see the anterior glenoid wall. From anterosuperior portal, you see the glenoid wall much better. Superb view all along the neck of the glenoid. So must see from the anterosuperior portal and not from the posterior portal. If you see better, you operate better. And of course, we know that there are 3 wives of the shoulder surgeon: the suprascapular, the axillary, and the musculocutaneous. This is where they are, and you must try and stay away from them. And how do you stay away? This is the safe triangle where you can pass your thick cannula. What is the aim of this surgery? I think the aim of the surgery is to rectify the pathologic anatomy. And what is pathologic? The capsule has detached from the anterior glenoid, and the capsule is also often loose. So you want to reattach, you want to tighten the antero-inferior capsule, and you also want to ensure that this soft tissue heals to the bone. That is the most challenging part of this operation, even today as we talk about Bankart repair. How do you ensure that this capsule will heal to the bone? There are very few studies which have proved that it has healed. So the main pathology what is the main pathology? Unless you know that, you'll not be able to rectify. It's antero-inferior dislocation. Evidence 1. Evidence 2, antero-inferior dislocation. Here I'm looking posteriorly. It's not anterior, antero-inferior. Evidence 3. You can see a large Bankart lesion. Ignore the Bankart lesion. Watch the inferior pole of the glenoid, and this is posterior inferior. I will pass a probe inside and show you how the labrum is detached all the way behind. All these are telling us that the instability is not anterior, it's antero-inferior. It is important to appreciate this, because only then you will design your surgery such that you tighten the whole hammock. And unless you rectify the pathology, you will not have a successful procedure. So the aim, I remind you all, is to reattach the capsule labrum complex and to tighten the whole inferior complex. And third is to ensure that this tissue does heal to the glenoid, which is the biggest challenge. So this is how you tighten the whole thing from front to back. Now I have an experience of more than 1,600 cases. I have a recurrence rate of 8%, fairly successful. keep in mind that the extent of injury to the capsule labrum complex can be variable. It's not necessarily the same amount of damage to the capsule labrum complex. I'll just give you some little flavor. This is type 1, my classification, Bankart lesion, labrum intact. Bankart lesion, labrum is gone, it's dissolved, it's stuck somewhere there, it's not visible. Type 3, interstitial damage. This is the dangerous variety. It has a high recurrence rate because there is a lot of poor capsule, as Nilesh Kamath showed a video of a poor capsule. So this is one of them, type 3. Type 4 is a bony Bankart, and type 5 is without any Bankart lesion. So all this variable extent of damage to the capsule is because of variable constitutional disposition of the collagen tissue. Every human being has a different kind of quality of collagen, and therefore the quality of capsule varies from human being to human being. And poor capsule will be seen in almost 36% of our population. I have solid hardcore data on that. Sorry, 38.5% will have poor collagen, and therefore they are at a high risk of recurrence. And unless you understand this, you will not design and execute your surgery well. So I have defined capsule type. You have thick, high quality capsule, then you have a little bad capsule, not well developed antero-inferior glenohumeral ligament, and then you have still further almost absent and absent. So the capsule variety can vary. So what are the tips? Now that you know that what is the pathology, what is the aim of surgery, the first and foremost is that you want to tighten the capsule all around. So mobilize the capsule well. You must tighten the inferior component, front almost up to back up to 6, 7, 8 o'clock position if required. Minimum 3 anchors. Somebody showed that case with 1 anchor, I think Ram showed. So that's terrible. Minimum 3 anchors in front, occasionally 4, but 3 anchors is the basic. You have to be a master at knot tightening. So here is my technique. So first I have entered the shoulder from the posterior portal, as you should. And you first get an idea about the lesion. We'll have a little better perspective as you withdraw the scope. That's the biceps tendon. That's the Bankart lesion. If you use my classification, this is type 1. So here is the biceps. You create your antero-superior portal behind the biceps because you can operate posteriorly also. If you keep your scope behind the biceps, you can see anterior, posterior both equally well. The big operating cannula comes just above the leading edge of subscapularis as inferiorly as possible because our area of attack is the lower half of the glenoid. So I'm not at all surprised that the labrum damage is going all the way behind. I see that in almost every patient. I will assess the quality of capsule. I'm measuring the thickness of the anterior band of IGHL because I can predict the behavior of the Bankart repair. How will he do? Then I will spend half the time in mobilizing the capsule and preparing the bone. If I do this surgery for 40 minutes, then 20 minutes is spent in just doing this. Why? Because the biggest challenge today in orthopedic remains how to get the tendo-achilles to heal to the bone, how to get a flexor tendon to heal to the bone, similarly how to get the capsule to heal to bone. So I have spent a lot of time making that edge raw. If you see that, I took a curette and I actually scraped away the anterior glenoid. And I have now a paper getting published soon, double-blind control study, 50 cases curated glenoid, 50 cases not curated. And there is a statistically significant difference between the two. It is important to curate that edge of the glenoid. There you see. And then this is very typical. You use various types of suture passers, whichever you like. I put the anchor first. And my suture passing is distal to the anchor, about 8 to 9 millimeters. So I do a capsular shift effectively. So my anchor is here, but the capsule is being pierced distal to the lowermost anchor. And these days I use double loaded all the time. And then you railroad one of these sutures. I have a minute left, and then you tie the knot. And I will do that 6 times, twice for each anchor, progressing from distal to proximal. So what is the current problem? Why we have 8-10% recurrence rate? I think it is the poor capsule. And this poor capsule, at the moment, we have no control on it. That's the way the patient's constitution is. And I think that is partly genetic. And of course, the bone loss. When there is significant bone loss, this operation will fail. A lot of speakers in the first half have talked about bone loss, but what I want to remind you all, that at least in India, this kind of extensive bone loss of 25% and above is seen in less than 10% of cases. In my practice, 6%, 5 to 6%. So you are struggling with bone loss in only 5%. 95% do not have that kind of bone loss. It is seen in 5%. And we don't play unnatural sports like rugby. So don't forget that the capsule is the god, capsule is the key, because it has mechanoreceptors. And things can go wrong. Don't use metal anchors. I've not used them for 22 years. I will not use them. Some of the first generation bioanchors can have a tissue reaction, which is unacceptable. But the third and fourth generation are pretty good. It's a successful operation. This is about 2 minutes if the organizers allow me. It's just for the younger audience. Some of you may have seen it. Forgive me for the repetition. But it makes the whole procedure very simple, like a cartoon film. That's the Bankart lesion, lateral position. Scope goes posteriorly. Now my scope will go in the anterosuperior portal. From here it has gone here. Abrade, spend a lot of time in abrading, curate the anterior edge of glenoid, curate it. Otherwise the capsule will not heal. Pass anchor 1. Here it is shown as single loaded, but you may use double loaded if you wish. Take the suture which is facing the capsule, take it behind, pass the suture passer distal to the hole, join the two and pull it through. Do that 3 or 6 times as you please, if it is double loaded 6 times. And in those 36% of cases with poor capsule, capsule type 3, capsule type 4, I will add posterior inferior capsular tightening surgery. As I said, any surgery which restores anatomy, which corrects the pathologic anatomy, has to be successful. So if I do this, I'm trying my best to restore the pathologic anatomy. So this is what I would do in those 36% of cases. Thank you very much, organizers. Thank you, Pune Shoulder Course.